Good evening, everybody. Welcome to this webinar that we organize to discuss all the specificity of outpatient surgery. I want to introduce myself. I'm Pascal-André Venditolli. I'm an orthopedic surgeon working in Montreal who spend a lot of time trying to improve patient care through outpatient surgery to reduce the burden of such a procedure. We're pleased that you made the time to join us for this important topic and enjoy the speaker's expertise for this session. We wish to thank our partner, Healthcare Excellence Canada, Choosing Wisely Canada, and the Canadian Association of Physical Medicine and Rehabilitation. I have a few housekeeping note for you. Please keep yourself muted and your video off for the duration of the presentation. There will be a Q&A session following each speaker presentation for 1 or 2 questions. And at the end of all presentation, we'll have a discussion, an overall discussion, including all the speakers. This webinar is accredited by the Royal College of Physicians and Surgeons of Canada. Your certificate of attendance will be provided after the webinar, but please make sure to complete our survey. The link is in the chat, so you can continuously improve our education offers. Take note that this meeting will be recorded, and you will have access to the recording after the meeting. To begin, I would like to acknowledge that the island of Montreal, that has long served as a gathering place for many First Nations, including the Mohawk, Huron, Wendat, Abenaki, Anishinaabe people, we recognize the Indigenous peoples as custodians of these lands and water, where the Canadian Orthopaedic Association has been headquartered since 1949. I will start by showing the slides that you see that bring you some important documents that you can find on the Healthcare Excellence Canada, providing very useful information for people who would like to implement a clinical pathway for inpatient or outpatient enhanced recovery protocol in their institution. This protocol that you will find on the internet has been the result of the discussion, collaboration of more than 20 experts from across Canada, and there was an endorsement by the COA supporting such a great collaboration between all these experts. One of these experts that participated in this clinical pathway creation is Dr. Brent Lanting, an orthopedic surgeon from Western University. Dr. Lanting specialized in adult hip and knee reconstructive surgery, enhanced recovery, and biomechanics. His research interests include surgical outcome and improved patient recovery. Thank you, Dr. Lanting, to be here with us tonight, and I will give you the podium to share your presentation and start this evening on a very important topic, discussing about how to minimize the problems after outpatient surgery. Brent?
Thank you very much for your introduction. Let me see. All right, let's get my slides looking good. Okay, thank you very much for your introduction. It's a privilege to be presenting tonight, and it's an honor when I see some of the names attending are people I look up to and our colleagues and friends across the country, so thank you. I do have a number of conflicts. I'd like to start off my presentation by discussing a simple definition. Historically, sometimes people would define outpatient surgery as occurring within 24 hours of surgery, but for the purposes of this talk and for our current communication, we'll define outpatient surgery as a discharge on the same day as surgery. I'd also like to highlight that although some propose that there's an imaginary arbitrary line between Canada and the US, I'd like to highlight that these are distinctly different entities and that our Canadian outpatient model is hospital-based and where the outpatient care pathway is folded in and included in our traditional care model, whereas the American model is often based using an ambulatory surgical center and which exclusively often provides outpatient surgery. So very different things. And for the purposes of our talk tonight, we will try to highlight solely Canadian literature. In 2014, in response to the limitations in bed opportunities, at LHSC, we started to do outpatient surgery. At that time, hip replacements took about 2 days before discharge, knee replacements 3 days. Since that time, I've personally done about 700 outpatient surgeries, and that's in context of an institution that does a high number of outpatient arthroplasty, so we have some institutional expertise. When we started outpatient surgery, we approached all the various stakeholders and used a multidisciplinary approach to create a care pathway. Our inclusion criteria were defined as ASA less than or equal to 3, English comprehension, with a caregiver available with access to phone. We did initially have a limited radius of distance from the patient's home to the hospital, but have gotten a little bit more inclusive in that regard, just in response to the patient performance. Exclusion criteria includes narcotic dependency, history of anesthetic complications, morbid obesity that affects mobility, or deconditioning that affects mobility, penicillin anaphylaxis, significant psychosocial issues, or limited cognition. Failure to respect either the inclusion or the exclusion criteria can compromise the safety of the patient and compromise the success of your outpatient care program. We did do a 360 evaluation to make sure that safety is adhered, and we recognize that the caregiver is uniquely pivotal for a successful outpatient surgery program. And we really need to focus our education inclusive of the caregiver. So when we built our care pathway, it did feature preoperative physiotherapy, comprehensive pre-admission instruction, and the discharge criteria must be the same for inpatient and outpatient. If you lower the bar, so to speak, for discharge criteria for your outpatient care pathway compared to your inpatient, you're highly likely to have a diminished success rate and a higher readmission and return to emerge. Patient safety will be compromised if you minimize your discharge criteria. Now, initially, there was limited uptake locally and across the country for outpatient surgery, and that's due to a variety of barriers, including funding. However, when outpatient surgery became QBP funded in Ontario, there was a significant uptick in outpatient surgery, and especially during COVID, when there was a paucity of inpatient access and only outpatient surgery was permitted. This resulted in Wolstead et al. Publishing a huge transition toward outpatient surgery. Now, looking specifically at outcomes and to examine patient safety, we did a systematic review. Now, this systematic review is largely based on American literature, and is the only paper discussed tonight that will. And it really shows that there really wasn't that much of a difference, no difference at all, in fact, between complication rates and clinical outcomes between inpatient and outpatient surgery. Looking at Canadian literature, the Ottawa group demonstrated that there was no significant difference between readmission, emerge visits, or adverse outcome between the inpatient and outpatient care pathways within 90 days. We published locally looking at the function of patients and showed that the patients that were treated with more intense perioperative physiotherapy in hospital had no difference in gait than the outpatient that just received preoperative physiotherapy education. Looking at higher level evidence, this randomized controlled trial funded by the PSI Foundation showed no difference in adverse events between outpatient and inpatient joint replacement, but the outpatient cohort, in fact, had better patient-reported outcomes and significant benefits in cost savings. The Ottawa group, led by Dervin et al., demonstrated that long-term, there is no difference in patient outcomes, and there was no difference in emerge visits or readmission, again, indicating a long-term patient safety. There's a challenge, though. Dr. Habous et al., where I'm fortunate to be a co-author of, had a paper accepted 2 days ago demonstrating large cost savings. And this has been consistently demonstrated in literature, demonstrating large cost savings. Now, as we recognize and desire to implement these large cost savings, there's a desire to maximize outpatient cases. And we really need to be cognizant of these pressures and have a careful balance in our ability to absorb potential failures of the outpatient care pathway. This may result in us needing to have a fallback plan for patients, etc. It also highlights our need to consider future patient safety. Are we going to progress toward an American model where we have public payer surgical centers, or continue with our hospital-based programs? And that needs to be considered to continue to engage patient safety. The Hamilton group, led by Dr. Wood et al., demonstrated a 19% failure of outpatient care pathway intentions of a cohort of 527 patients. In literature, the range is 3 to 23%, which is a wide range, but the Hamilton group demonstrated 19% failure rate, typically due to hypotension, inappropriate selection of patient, an OR time later in the day, or a higher ASA at an ASA 4. They also curiously indicated a risk factor of total hip arthroplasty having a higher failure rate. I'm very appreciative of the advocacy of Dr. Waddell at the provincial level and Dr. Venditolli at a national level, working with the Canadian Patient Safety Institute to continue to work our overall desire for patient safety and to enhance that through knowledge translation, including the Enhanced Recovery Canada orthopedic pathways. I think we need to continue to consider barriers, but also to consider ways to optimize our patient care through improved safety using these standardized pathways. In conclusion, I think it's important for patient safety to organically develop outpatient care pathways as a progressive step from enhanced recovery pathway. And we know from our current state of literature, outpatient surgery can potentially provide improved or equivalent patient-reported outcomes with no increase in return to emerge or readmission and no increase in patient complication, resulting in us being able to conclude that patient safety is maintained at least at the level it is now with our current progress toward outpatient surgery. Thank you very much. And again, it was a privilege to be able to speak tonight.
Thank you very much, Brent, for such a great presentation. There's no question in the chat room. I would encourage people to write question, and we'll try to pass them to the speakers. For the moment, I will start with one question for you, Brent. You know, you have a long time experience of doing outpatient surgery, and your protocol is well organized. You improve many interventions over the time. What are the most important 2 or 3 factors of success in your protocol that you learn over time that we need to focus on to prevent failure of an outpatient surgery?
Thank you very much for the question. And I think all of us here would speak the same thing, that it's about communication, consistently communicating with the patient, their expectations, what their care path is going to look like, consistent communication with the caregivers, just to make sure everybody's on the same page. If we fail in our ability to communicate or provide 2 different care pathways, patients will unfortunately get confused about their expectations, and then you typically have a failure of your care pathway.
And to improve communication, do you have a leader in your hospital that a contact person for the patient that the patient will rely throughout the whole pathway, or it's many multiple person who play that role?
Unfortunately, in some ways, it's multiple people, but their chart is clearly marked from the beginning that they're on the outpatient care pathway. And once they're clearly marked, um, the message tends to stay consistent. And I think it's also a product of institutional, patient, and caregiver, um, all of them sharing in the success of the program. So it becomes very organic because patients witness the success of it, the institution does. So there's a combined desire to continue that success and therefore an impetus to remain good with our communication and tight with our communication.
Excellent.
I see a pop-up question. Most of the communication is, um, I wouldn't say it's necessarily uniquely the surgeon's office. My secretary does a lot of communication, obviously, but the pre-admit, the physiotherapists, my nurse practitioners, and potentially the physicians all interact with the patient. And I think a lot of their education happens there. So it's not uniquely my office.
Excellent. Thank you.
We do have another question. How can hospital leadership better support safe same-day discharge patient growth from Stephanie Jackson?
Thank you for the question. Very thoughtful, and it is a shared responsibility. I appreciate that question and leading us in that direction. I think a number of ways uh, the institution could support it, and one of them would be flexibility, recognizing that outpatient surgeries, as indicated by Dr. Wood, um, have a higher rate of failure if they happen at the end of the day. Recognizing that um, bringing those outpatient surgeries to happen first case or second case in the day and pushing potentially inpatient surgery later in the day, um, potentially improving physiotherapy access before surgery to make sure that the patients are well educated and have appropriate home care and appropriate expectations of discharge. Um, and having those clear communications, I think, are really important.
Excellent. Thank you, Brent. We'll move on to the next speaker. And at the end of the session, we may have more questions for you. So up next is Dr. Sebastian Rodriguez-Elzalde, an orthopedic surgeon from Humber River Hospital. Dr. Rodriguez-Elizalde is specialized in adult hip and knee reconstruction and has a special interest in robotic assisted total knee replacement. He's involved in teaching advanced surgical techniques and is also the fellowship director of Humber Hip and Knee Arthroplasty Program. Welcome, Dr. Rodriguez. So I'll leave you share your screen.
All right. Thank you, Pascal, for that introduction. Can everyone hear me? I'm not muted, and can everyone see the screen? Hopefully, we're good. So thank you very much for that introduction. I'm good friends with Brent, and I don't work at a prestigious academic institution like the University of Western Ontario. I'm at a small community hospital in Toronto, but hopefully we can give you a perspective of our experience with same-day surgery. Some of the efficiencies that we've discovered over the last several years as we move forward, and we can talk about how you can implement same-day surgery at your institution. In terms of conflicts of interest, there's a couple of companies that I work with that don't present any conflicts with the content of today's talk. So I think Brent gave a great highlight over sort of that historical view of same-day surgery in Canada and its definitions. And I think we all know that there's a trend towards this in Canada in terms of same-day surgery and what's being done. And it's been fueled, I think, as Brent mentioned, and as the Wolfstat paper mentioned, about a number of things. And really, the uptick was after the pandemic. And as orthopedic surgeons, we lost, in some institutions, 1 to 2 years worth of work because we're so dependent on hospital resources, where traditionally these operations are done, and we suffered and our patients suffered because of it. There's definitely a huge financial consideration, which I know administrators and hospitals are coming to surgeons to see how they can cut costs, and outpatient surgery is definitely one of the ways. I think decreased human resources. If you look at our orthopedic floor today, we used to have 2 main floors at Humber Hospital with orthopedic patients, and one of them was almost entirely filled with hip and knee patients post-operatively, and now that floor is virtually empty. So we have less nursing power. Every institution that I know of is looking for high quality nursing and allied healthcare professionals. And if you have less need of inpatient resources, I think you're helping your institution. And finally, I think there's a huge interest nowadays because, as Brent mentioned, at least in Ontario, there is a call for independent health facilities, which will be chartered and asked to do same-day hip and knee replacements. And so how can this be governed and sort of shepherded to be safe with good relationships? And really, what does the landscape look like in Canada moving forward? If we look here, the number of patients that had hip and knee replacement over the last several years, and you can see what percentage of those patients were outpatients across the country. And really, up until 2022, is less than 20% of patients were getting an outpatient hip or knee done. And if we fast forward that data there, you can see that the projection of this is likely higher in the last coming years. And I would challenge it's even higher than this if we're to look across Canada this coming year. And that's a huge jump. And we sort of mentioned what's fueling that, but how can you and your institution do this as well? And I think the success of such a program, as Brent elegantly highlighted, is attributable to several factors. I think you need great care amongst all the providers, and that starts at the surgeon's office. That really starts with things like anesthesia, and I think Pascal's group has done a great job of outlining a lot of the guidelines that are imperative to have this for success. Very good perioperative protocols and discharge planning. You need good patient education and good patient support. And so at Humber, all our patients are enrolled in a tracking app afterwards, the My Mobility app from Zimmer, but there are a number of different apps on the market that allow patients to have access to information virtually and instantly, and to be able to coordinate with a champion of hip and knee or a nurse coordinator if they need to. So how can you make your institution more efficiencies? And this is just historical, what we learned at Humber Hospital. And first of all, you need to have that education and engagement. You cannot explain to a patient that they're going to have a same-day hip or knee procedure the day of surgery. And this conversation begins at surgical consultation, or if they're meeting with an advanced practice care physiotherapist who's screening them before even seeing the surgeon. These people all have to be on board and understand that the care pathway at your institution could involve, or in our institution, we basically tried to streamline everyone to same-day surgery, that you will involve, it's a same-day procedure. And family and caregivers all have to be prepared, because everyone hates that discharge planning at the end of the day and it says, well, my mom can't go home or there's no one there. So for sure, you need to involve social worker and people ahead of time to make sure everyone has to be on the same page. When people come to hip and knee classes, all the content, all the information at our institution is all geared towards same-day discharge for patients. As much as orthopedic surgeons, we love to malign anesthesia and blame all our miscomings on the anesthetic protocols provided by our colleagues. Anesthesia buy-in is key to any successful same-day program. And a lot of the success at our institution, as much as I would like to take credit for it and the other orthopedic surgeons, is highly reliant on the success of anesthesia and what they've been able to do over the last few years. A combination of this, again, available with Pascal's group, or different institutions have slightly different cocktails, but multimodal medications given ahead of time are key. A low-dose spinal anesthetic is given without narcotics. We don't use general anesthetics for anyone, or for the vast, vast majority, over 95% that are getting same-day surgery. You need to have consistent surgical times. So, your anesthetist has to be able to tailor that spinal dose to this person's hip, this person's knee, how long it takes. And finally, if you're using an adjunct like blocks, I think that, these ultrasound guided blocks around the knee, most commonly adductor canal blocks, if you're doing a PENG block around the hip or a QL block around the hip, these all have to be done in a block room. You want to eliminate anesthesia from your operating room to be very successful, so it's consistent and done by a well-practiced practitioner. And you want to use the operating room strictly for surgery. In terms of, your anesthesia and ultimate efficiency, I really think you want to take anesthesia out of that operating room, as I mentioned. At our institution, all these blocks are done ahead of time. And we have anesthesia assistants which are able to monitor the patients intraoperatively when they're just being lightly sedated. I think these are very helpful for larger institutions and allowing anesthetists, again, to best practice anesthesia, which is instituting blocks and spinals, hopefully outside of the OR and in a block room. And parallel processing at our institution has allowed us to do higher volumes of surgery successfully with same-day protocols to maximize the use of the operating room. Intraoperative considerations. And I think this sort of piggybacks on a lot of the talk of anesthesia. And I think if we look historically and we look at what is safe, how is it safe to send someone home? Why are patients failing, or why are we keeping patients? The real reasons we kept patients in hospital after hip or knee replacement was for two things: pain control and blood loss. And I think if you look at historically, and I remember when I was a resident, which I would like to say is not that long ago, but now is longer than I think, people were all on PCA after to help mitigate their pain. And the PCA was a great invention because it allowed patients to not be in pain and constantly dose themselves with narcotics. However, we learned that this keeps people in hospital longer. And finally, blood transfusion. If we look at blood transfusions, across the country 10 years ago, anywhere from 40 to 50% of patients were getting blood. However, blood loss with use of surgical technique, hypotensive anesthesia, and obviously tranexamic acid, this problem has been largely solved. And so I think if you give tranexamic acid via whatever protocol that you're giving it, IV or topical or postoperative via an oral route, and we do actually all three at our institution, I think this will greatly diminish the need of blood transfusions and the necessity of having to check hemoglobin immediately postoperatively and on postoperative day 1, 2, and 3, which traditionally most institutions did. Intraoperative considerations, I think we have great anesthetists at our institution, which can give us, axial based anesthesia. However, you can augment this. And again, I think multiple groups have described different types of cocktails which can be used intraoperatively around the capsule and around certain nerves, both in the hip and the knee successfully. Ideally, you want a very consistent formula that all your surgeons will use at your institution. Your pharmacy can potentially prepare these ahead of time, deliver them to the operating room. They're mixed by the nurse ahead of time. And I think one of the keys to this is adding to that volume, diluting your cocktail with whatever you want to dilute it, be it saline, and dispersing this cocktail in and around the joint. And I think this helps to help control the pain after surgery, swelling and bleeding. This is not the forum to debate surgical technique. However, as surgeons, I think we can all do things to help minimize and have higher success in terms of same-day surgery. I know it's contentious to say that certain surgical techniques, for example, the anterior hip or less invasive knee approaches, could disrupt soft tissue less, but I think the reality is, and the literature will show, that certain techniques are associated with less postoperative pain. Less postoperative pain, I think, gives you a higher success for discharge after surgery. In terms of postoperative efficiencies and what we've done at our institution, there's a couple. I think the greatest barrier in terms of getting people out of your institution, and one of the ones that was highlighted by the McMaster group and Dr. Lanting, was what happens after surgery. If you're the last case in the day, are you going to be able to get that patient out of the PACU and seen by physiotherapy and go home? So PACU is a large issue for many institutions, and I'm sure the surgeons on this webinar today have all heard the complaint of PACU is on hold and you're waiting in your operating room. From there, you go to a same-day unit, or in our case, it's same-day center. It can be labeled different things after PACU before you go home. And another barrier is physiotherapy. You have to have physiotherapists on hand and be able to make sure they're seen, assessed, taught, and then able to go home. So this is the traditional flow through that we have after your surgery. And as surgeons, we can really control the surgery, but you want to be able to think that whole flow of surgery and as it goes through your institution, and can you set it up to be efficient to help with same-day surgery? And in terms of why do patients go to PACU, or the post-anesthetic care unit? Again, traditionally, it was because we used general anesthetic. Patients needed to wake up. They were in control. So all of a sudden, this anesthesia stopped. The nurses were there, and they're pushing morphine or Dilaudid or something to help get pain under control. As soon as we do this post-operatively, the patient then has nausea, vomiting, could be going to sleep, their volume issues. So people are in PACU to help resuscitate literally the patient after their surgery and then get them to the floor. And finally, hemodynamically. After surgery, traditionally, people went to PACU to get a post-operative hemoglobin check to see if they would be a candidate or potential candidate for blood transfusion. And I would argue that when people come to the hospital, traditionally, they were being admitted to hospital because of these reasons. People nowadays are coming to hospital to have a procedure. They're not sick. They're not being admitted to hospital because they're sick in any way. They're coming literally to get a procedure, which in other places or in the US can be done in an outpatient setting very successfully for the vast majority of people. So we have to rethink, why are these people going to PACU? Why are they being admitted to hospital? And these reasons have completely changed. So can you skip the post-anesthetic care unit completely and go straight to your same-day unit? And at Humber, we did institute this. And the conditions for this is no general anesthetic. You have to have a very light, spinal, and you have to be awake almost literally as you leave the room. So on top of being awake, you have to be moving. So no motor blocks. So traditionally, a lot of places use femoral nerve blocks, which are great for 24 hours and provided pain relief. However, the patient could not ambulate. So whatever blocks you're doing from your anesthetic perspectives, it cannot impact the motor function. Both of these scenarios, if you're awake and you can move, you can start to do physiotherapy and be discharged much faster. And does PACU and does SDC make a difference? All our patients go to PACU, they can go home from there. A lot of institutions tell me, and I'd say that's great. But if we look at a PACU bed and an SDC bed, to us and for myself, the uneducated surgeon, they really look the same. But what are the advantages of having a healthcare practitioner in either scenario? So at our institution, there's a big difference, and I'd argue in yours as well, and you should probably take a look at this. And if you're in PACU, as mandated in Ontario, you have a 1-to-1 nursing ratio for the first 45 minutes. That nurse is watching that patient. After that, that nurse can now look after 2 patients. So in terms of manpower and involvement, it's quite heavy. If you go to the same-day care unit at our institution, it's 1-to-2 for the first 15 minutes. So that nurse in the first 15 minutes can take care of 2 people, whereas in the first nurse, you can only look after 1. And after 15 minutes, you can go to 1-to-3. So there's a significant difference in terms of what your manpower can manage, because these people are not needing transfusions, not needing to be woken up. They're very stable, they're comfortable. And so there's a huge savings with that in terms of what you can do to lean out your entire process. And so really, what does this amount to in terms of results? And is this safe to send people straight to the same day unit and not to PACU? And I would propose that there's a lot of difference that it can make. First of all, look at the savings. In terms of less transfers, every time you take someone from the operating room to PACU, there's a porter that's involved. A nurse has to take a handover. There's communication that has to be done, staff that has to be involved. That place in PACU has to be cleaned then by housekeeping after for the next patient to come, and then they have to be transferred to the same day unit. If you can eliminate that entire step, you've eliminated one extra porter visit, you've eliminated housekeeping to have to go there, you've eliminated the handover that has to be communicated on. So there's a lot of savings that you don't initially realize, both in money, but in time and in effort. So I would argue that we unnecessarily provide a lot of this stuff for things that were historical considerations when patients needed to go to PACU. And if you start to look at how you can make your process better, and you can model this after a lot of the ambulatory centers in the US, you can really have gain savings for your institution. Finally, there's a financial incentive for this too, because if you think about the manpower that's necessary for the rehab and recovery of this patient, it's significantly less. So as I mentioned, there's just less people. At our institution, 72% of all our patients can bypass PACU. And there are criteria that require people to have to go to PACU if they're on an obstructive sleep apnea machine at home, if there's certain cardiovascular criteria that our anesthetists feel need to be monitored immediately post-operatively, then yes, these people do go to PACU. But interestingly, almost 3/4 of patients do not need to go to PACU. At our institution, about 85 to 88% of all our total joint replacements go home the same day that are primary total joint replacements. And those that go to PACU, about half of them are admitted. So for us, PACU is a conduit largely for admission for a variety of different reasons. And typically it's because of monitoring for some form or for a lack of home supports, as Brent mentioned earlier. And those patients need to be admitted to PACU to then go upstairs. They don't go home from the same day unit. And is same day discharge safe? And I think everyone wants to avoid readmission. So it's easy to get people out the door, but are they going to show up at the doorstep the next day? And I think that's one of the biggest things is people always scream with same day surgery is it safe? Our experience just last year in terms of looking at single hip, so this is just total hip arthroplasty, which is interesting because the Hamilton group said this is a higher failure rate. And what we found there is that almost 90% of our patients were able to go home safely. And many institutions have outlined criteria to send people home safely. And we actually decided to eliminate all criteria and just assume every single patient that presented with a unilateral total joint replacement was a candidate to go home. And again, the failure rate for this was less than 15%. So less than 15% of people needed to be admitted. And we did not find independent risk factors that some people mentioned in terms of ASA score or age or weight to be any criteria that were correlated to the people that were admitted. It was most likely to people for geographical distance, how far away they live from the institution, how long it take to get home, and then the supports that they had at home, as in if they lived alone, they were not unable to be discharged safely back to their institution, back to their home. So if we looked at this 3-year data and we compared it to all the patients that stayed at Humber without using really a selection criteria, we found that there was no difference in terms of complications, in terms of infections, 30-day mortality, or 90-day hospital follow-up. So in terms of the stringent selection criteria, what I think we initially applied to total joint arthroplasty, I think we can seriously consider having to loosen these, because I think really it's about the setup of the home and the social factors that these people have, and less about the medical issues that they present with. Finally, in conclusions, I think that, look, a same-day program is very successful, and I've been blessed at Humber to have forward-thinking administration and colleagues that have supported us, both from the anesthetic side and my surgical colleagues, to really help get people home safely. And I think the majority of every hip and knee in Canada can be seriously considered as a same-day discharge. I think this is safe and is reproducible at our institution, where we do over 2,400 joints a year. It has been shown to be that. And I think your surgical flow has to be looked at. So you can't just look at the surgical technique and the surgery, but you have to look at all the factors around this and how you can help make this better for that flow. But realistically, what I want to follow up with that is that that program success depends purely on the team. And I think that's your nurses, your physiotherapy, the anesthesia, as well as the surgeon and administration. And I think I've learned this in the past. If you want to go fast, you go alone. And people have quoted this as an African proverb. But I think the reality is, if you want to go far and be successful, you have to go together. So you have to involve the stakeholders at your institution that are going to help you have success. As a surgeon, you can't just push this and say, this is what we're doing. You have to get buy-in from everyone at the table. And I think really the last thing I'll leave you with is, if we look at why people can't go home or why surgery was done, I think it's really because of the way we were thinking. And this bridge in Honduras was built in, I think, 1996. They have a lot of hurricanes in Honduras. They chartered a variety of experts from around the world to build a hurricane-proof bridge, which is indestructible. So this bridge in Choluteca, Honduras was built, is a technological and engineering marvel, and they built it to solve the problem. And it worked very well. And in 98, 2 years later, they had a giant hurricane that came in and changed the way the stream was affected. So their institution built something which was very good for its construction at the time, but the purpose has been completely redefined. And I think us using hospitals and the idea of admitting people to hospitals for total joint replacement is very close to this sort of analogy, in terms of what we've built is very traditional and based on historical reasons. And we have to rethink the modern day patient with modern day anesthesia, surgical techniques, and medications and information is different from what we were doing 20 years ago. And so we don't have to be doing the same things we were doing in the past, because we have new problems to solve. And with that, I'll leave you. Thank you very much. If anyone has any questions or wants to reach out to me about our institution here, there's my email on the screen. Be happy to answer, or put you in contact with the people at our institution that were able to provide those answers. Thank you.
So we do have a couple of questions here, if that's okay, Dr. Rodriguez. Would you mind sharing your protocol for TXA route and timing of administration, as well as a second question here? But if you'd like to answer that one first, that would be great.
In terms of tranexamic acid, I think most of us are giving 2 grams of IV tranexamic acid prior to surgery, along with NSAID or your antibiotic of choice. Most of us are mixing tranexamic acid at the end and putting it locally, both in the arthrotomy of the knee, injecting into the arthrotomy of the knee once it's closed, or into the hip joint before capsular or fascial closure. And then we give people a 3-day post-operative oral tranexamic acid dose that's in a blister pack. And we do a blister pack because people are getting a lot of medications post-operatively. with anti-inflammatories, dexamethasone, tranexamic acid, and I'm happy to provide the recipes for this if anyone reaches out via email. We've had a lot of success with this. Is the brainchild of one of our anesthetists. It's a blister pack so that your elderly patients will have the timing of all their medications, and we separate from that narcotics. And what we found is, 80-90% of patients don't even use narcotics after hip surgery. And now with new advanced protocols, even, almost approximating that, I'd say 2/3 of patients don't use any narcotics after knee replacement surgery. So I think tranexamic acid has a role, IV, topically, and postoperatively as an oral adjunct.
Perfect. Thank you so much. We do have one more question here. Could you please share your criteria for DSU versus PACU?
So that's still more contentious. And again, I think you have to approach the idea of same-day surgery. Everyone's like, what's your criteria to go home? And I say, what's the criteria to not go home? And again, with your anesthetist, you can battle this and say, what's the criteria to not have that patient go to same-day surgery? So I think they have to, at the end of the beginning of the day, we review. And I'd say typically 3/4 of our patients are able to go to same-day surgery. Basically, the major ones are people who are dependent if they have difficulty waking up after deep sedation. So people with obstructive sleep apnea, people that need admission. So there are people that live alone that need admission that don't go to same-day surgery. And as well as anyone who needs cardiovascular monitoring, be it previous history that anesthesia or internal medicine has deemed needs to be monitored for the next 12 to 24 hours. That patient can't go to same day, they go straight to PACU as well. But again, I'm happy to email the formalized criteria from our institution if anyone needs.
Perfect. And one more question here, and any more that come in we'll save for the end of the webinar, but are you sending patients home with nerve catheters?
Yes. So our hip replacements at our institution, 7 out of 8 surgeons, I believe, are doing the anterior hip replacement. And so they don't have any nerve catheters. They do a PEG block with anesthesia and a spinal anesthetic and local infiltration. In terms of knees, we are doing a spinal anesthetic, and then we are doing an adductor canal catheter. I think this has a huge role in terms of total knee replacements and your success with total knee replacements going home. I think anyone can send any patient home via surgical approach or whatever you want to do with anesthesia. You can block that patient very successfully for the first 12 hours. Does that patient bounce back because of pain after? I think having an adductor canal catheter in the knee, which at our institution lasts 72 hours, is a 60 cc bottle that basically the patient pulls out. Anesthesia calls them on the phone on day 3 and they just pull it out themselves. Has been a game changer in terms of knee replacement surgery. It minimizes pain to the point where, as I mentioned, most people aren't even taking narcotics now because you've gotten over that bump of pain in the first 72 hours with that. To the point where my knee revisions are able to go home same day now with the same catheter. So I think it's a game changer. If your institution isn't doing it, I'd ask you to reach out to our anesthetist to talk about it and look at it, because it doesn't take any extra time, but has a direct benefit for patients.
Thank you very much, Sebastian. So we'll move on to the 2 next speakers, Dr. Meiqi Guo, the medical director of the brain rehab program at UHN, and Danielle Jepson, the advanced practice leader at UHN, who specialize in interprofessional teams caring for patient and complex needs. They are both representing CAPM&R here today with their topic. So I welcome you both, and please be on the podium.
Thank you so much. So before we start, our conflicts of interest are listed on the slide. And we really want to thank you for the opportunity to present on Therapeutic Falls, a toolkit for embracing risk, enhancing autonomy, and accelerating recovery in rehab. And if you'd like to browse on something while we're talking, please do check out our toolkit at therapeuticfalls.ca or use the QR code. These are the objectives of our talk. We're going to start off our little talk with a case that illustrates why we created the concept of therapeutic falls at Toronto Rehab. Ms. X is a 70-year-old lady who's recovering in hospital after a hip fracture. She lives alone. She has always been fiercely independent, and as she recovers, she insists on going to the bathroom without assistance. She currently requires supervision for ambulation using a 4-wheel walker. And she's very upset about these bed alarms that are going off when she tries to get up on her own. She doesn't want to, use the call bell to call. And she tells you when you round on her, I know I could fall and break my hip again, but I'm not waiting 30 minutes to go to the bathroom. It's not like someone's going to help me when I get home. And by the way, I fully intend to go home. I only have a nephew as family, and he's useless. So it was for patients like Ms. X that we created a concept of therapeutic falls. Here are some other things that we consider when creating this concept. So first is that, zero falls doesn't mean zero harm. There's definitely physical harm from immobility, like, DVTs and PEs, and there's also harm to a person's dignity and also to their mental health from keeping them cooped up in bed. Falls could also be the natural outcome for some patients as they strive towards independence and may reflect effort and recovery. Just like, when a child's learning to walk, they could fall. When somebody relearns how to walk after injury, they could fall. And another thing we consider is that keeping patients safe in hospital doesn't necessarily mean that they're going to be safe at home. I mean, they could fall at home because they did something we told them not to do, and then they can lie on the ground for 3 days and not be found. The last thing that we consider is that despite all our efforts at a just culture, healthcare providers still can feel shame when their patients fall. And as a result, we tend to adopt the overly custodial approach to mobility, and we avoid discussing risk with patients and family. So with those things in mind, a whole group of patient partners, therapists, physicians, and practice and administrative leaders at Toronto Rehab created this concept of therapeutic falls, which is a fall that happens during a higher risk activity that the patient has chosen to practice to promote independence as part of their recovery. This activity is one where the patient feels the potential benefit exceeds the potential risk for harm. And a therapeutic fall has 3 components. The person or their substitute decision maker has to have chosen to pursue this activity as part of their rehab in collaboration with their care team. So it can't be just like, yep, I'm going to decide I'm going to go and climb up some stairs now. The substitute decision maker or the person has to be able to consent to it. So they got to understand and appreciate the consequences and risks of falling. And there still has to be a focus on falls prevention and harm mitigation strategies. It's not like, okay, well, now we're going to be on a therapeutic falls pathway because you are doing something that we don't want you to do. And now we wash our hands of anything that happens. No. We still got to help them, and we still got to try to reduce the harm of falls. So what we're suggesting for therapeutic falls is that, in hospitals, we tend to classify falls as a preventable fall or as a non-preventable fall, or at some hospitals, a serious safety event or a non-serious safety event. And what we're proposing is that we should add therapeutic falls as another category of falls when we're characterizing and when we're measuring patient safety outcomes from falls. So now I'm going to hand it over to Danielle, who is going to talk to you about our results from Toronto Rehab over the past 3 years as we implemented therapeutic falls.
Thank you, Dr. Guo. So we have had over 100 patients participate in this pathway over the last 3 years. And we have seen some really wonderful changes. So initially, I think everyone's thought was that if we were allowing patients to kind of choose their own destiny while they were in hospital, that we would see falls rates go up. In fact, that wasn't the case. So when we look at our run charts, we've actually seen that our falls rates went down on 1 unit or remained the same. We also saw in our FIM change, so FIM being the functional score that patients get when they're admitted and discharged from rehab, was significantly higher for patients who were on therapeutic falls compared to those that weren't. And although it wasn't statistically significant, the odds of patients on the therapeutic falls pathway being discharged home was higher than those who were not. From a qualitative side of things, we went through focus groups and one-to-one interviews with patients, caregivers, providers, champions, leaders, and we did learn a lot. So our providers are telling us that often they're proven wrong. Patients are doing a lot better than they thought they would, and it's often us that's holding them back in the name of safety. And they're saying that patients' moods are improving, patients are thriving with this pathway. Our patients are telling us that they're able to return to fitness sooner. They're regaining their mobility faster, and they're able to transition to the community more successfully. So we have been getting a tremendous response to this idea as we present this across the country and internationally as well. So we have developed a toolkit for those who are interested in bringing this work to their own organization. And it's available for you at therapeuticfalls.ca, as Dr. Guo mentioned, or at the QR code on your screen. And we've got it divided into 4 steps for you there. So you can get a sense of where your organization is at, if they're ready to allow patients to take more risk within their hospital, and then go through an adaptation process. And we certainly have learned that every context is different. And I think the orthopedic world and same-day surgery in particular will need some adaptation for this work, but we're happy to help you with that if you're interested in trying this with your populations. Step 3 would be running workshops or training sessions with your team. And again, we have slide decks and facilitator notes on how you can do this with your team. And then piloting. And we do have an evaluation framework and suggested metrics for you to check out as well on our website. So that's all available for you there. So in conclusion, a therapeutic fall is a fall that happens during higher risk activities that the patient has chosen to do while they're in the hospital. And it's a part of their recovery after deciding that the potential benefit outweighs the potential risk. So we strongly feel that this concept is applicable beyond rehab, and we're happy to share it with you this evening. Certainly in clinical situations where you're looking to get fast motor recovery, allowing patients to take more risks is certainly something to explore with your teams. And we would like to acknowledge the many, many people who are involved in the development of this work. And we welcome any questions.
So we do have one question here, is that can you show us what's in the Therapeutic Falls toolkit?
Yes, I can. And I will actually pull it up. So if you go to therapeuticfalls.ca, you actually come directly to our toolkit. And what you will see is that if you navigate to the toolkit, we break it up into the different steps. And you can click through and follow it. We also have a whole resources section, and it has different things like, for example, signage, so that the team knows what's going on, and that they can use that to be able to communicate more easily with each other. And also various other resources like presentation slide deck, so that the whole team can learn about what it means to put patients on therapeutic falls pathway and what is involved. So that's what the toolkit looks like.
Excellent. And what is your feeling at the benefits of your toolkit with outpatient surgery? How should an outpatient team could apply your protocol to reduce the risk of the patient going back home and having a fall?
Yeah, it's a great question. So I think there's a lot of value in the outpatient world. It's really around mindset and the philosophy of care, and how we view risk and how we discuss risk with patients. And I think this toolkit is designed to tackle those patients where you're coming up with those discharge barriers. These are the patients who live alone. They may not have the support person there. And this is how we're really using it in our organization, is to support those patients who do want to try, despite the fact that they may not fit the traditional profile of who you might traditionally send home, for example, for a same-day surgery. We're giving these patients the opportunity to make that choice with the support of their healthcare team. So I do think there's opportunity to explore how we can better support these patients to make these choices. It's always sort of it's the tricky ones. It's never the straightforward ones that fit into this bucket.
Excellent. Thank you very much. So we'll move on to the last speaker. We'll bring up a patient partner who will share with you her experience to the audience in the panel. We thank Meiqi Kerestici for being here. It's time to get us thinking about our own patient partnerships and how we can improve surgical safety. So, Meiqi, if you can share your screen and
Right.
your experience.
Great, thank you so much. And thank you for trying to pronounce my name. Most people don't even attempt it, so I appreciate it. These are just the organizations that I've worked with in the past, so no conflict with what I'm here to talk about today. So I want to thank you for inviting me tonight and for proactively including patients and caregivers in your discussion about patient safety. I really appreciate the fact that several of you have mentioned the importance of not just speaking with, but communicating consistently with patients and with caregivers. People often ask me why I got involved in this kind of advocacy. So if I may, I'd like to start there. This is my why. This is my sister and I on her first day of chemo for breast cancer. And just when we thought that particular beast was in the rearview mirror, she was diagnosed with a rare appendiceal cancer that required a 14+ hour high-PEC surgery, many weeks in the ICU, and countless complications. And our family story is one of what happens in a fragmented system, of what happens when the system loses sight of our North Star, and that's the person in need of care. I got involved in advocacy when it became clear that not only did she need someone to help navigate the system with her, but that she needed someone who was a captain of the ship, someone to bring her story together and hold it, and someone to try and transition her team from a multidisciplinary team to an interdisciplinary team, and someone who could speak on her behalf when she could not. I am also a caregiver to my 92-year-old mother, who lives with me and who broke her femur and her hip a couple of winters ago. I'm a patient with a solitary kidney and palindromic RA, and I've had several orthopedic procedures, including 2 spinal fusions. As patients, we don't enjoy retelling our stories. In fact, it's really difficult to do that. But we do it because we believe that by sharing our unique patient insights, we can be part of something, part of creating a better system that's inspired by the insights and needs of patients. So my entire career has been in healthcare. But as it turns out, all I really needed to know, I learned in caregiving. I've worked in clinical settings, in analytics, in health policy. In fact, I managed the CJRR several years ago when I was working at CAI. But in fact, I've learned far more about healthcare delivery in the time that I've been a caregiver than I have from any textbook, any conference, any work experience, or any professional accomplishment. I want to spend a few minutes with you discussing how patient and caregiver insights can be leveraged at an individual level at the bedside and at a system level. So let's start with the personal. I don't know if we have time. I was going to play an audio clip for you from an orthopedic surgeon in the UK. I'm going to give it a shot.
Care in my hospital was amazing. She had courtesy, reliable care, efficient care, expeditious care, safe care, the very best that medicine could offer. And most importantly, she was better. I felt quite proud, actually, that my mother could see how great my hospital was and how great the staff were. 2 months later, I visited her at her house, and I just happened to ask her, "So what did you think of my hospital?" And what she said after this, words can't even describe how I felt. Ashamed, guilty, like I'd betrayed her, probably sums up what I felt. And she said that the 2 days I spent in hospital was the worst experience of my life. I spent 2 days petrified, not knowing what's happening to me, what was about to happen. And as far as she was concerned, she wasn't going to make it out of the hospital and see her grandkids again. How can a mother's son, who is a doctor in the very hospital that she was at, not see the world through her eyes? And if I couldn't see the world through her eyes, with my mother that I dearly love, then what chance did my patients have whom I didn't know?
So I don't know if I hope you heard it, But his message is basically that we can't assume that the outcomes that matter to your hospital or to you as a clinician are the same outcomes that matter to your patients. We have to ask about and understand what matters to people. I'd also encourage you to include essential care partners. I was so heartened to hear Dr. Lanting speak about the importance of caregivers and care partners. When you're doing safety planning, they're vital to the safety and well-being of patients. In a system that's as disjointed as ours currently is, sometimes the caregiver is the only person who is the full story. In my family's case, I literally brought 5 binders to each of my sister's appointments, as full information just was not necessarily available to the multiple specialties involved in her care. One of the things that I've been thinking about is the experience we recently had with my sister. She fell and she had a bad break in her humerus that required surgery. The surgeon and the hospital were great and had done their due diligence by giving her a discharge plan, which was designed to keep her safe, ensure she was booked for physio, that she was booked for rehab, and that she had follow-up appointments. What was missing was communication with me, her caregiver, beyond the specific surgical experience. She still has neuropathy from her chemotherapy, and that neuropathy makes her prone to falls. There was no mechanism to be sure that this was communicated and considered in her plan for home and recuperation. There was also no conversation about the situation at home other than confirming that someone was there and she wasn't alone. I'm not always physically able to provide the best care if I'm having a flare-up, but again, that wasn't addressed in her plan. These are small details, admittedly, but they're things that can make a big difference between a safe and full recovery and having to return to a MeRG or hospital. My mother's story shares many of the same themes. My mom is a feisty 92-year-old Irish woman who absolutely reveres doctors, and she takes every word that you say as the golden rule. She will never voice that she's in pain, nor will she ask questions of you. When my mom broke her hip and femur, I had to be persistent in advocating for her because she would not. So I want to shift gears a little bit here and talk about welcoming patient and caregiver partners into your decision-making about the design and development of policies and programs that impact safety and care at an organization or system level. So the historic trajectory in healthcare has evolved over time. We began in a sad place that was unidirectional sharing of information alone. We moved to trying to engage patients and families more, which is where many organizations remain today. But what excites me is where we're going. We're going to an era of co-defining and co-designing care, where power is shared equally and everyone contributes. It's my view that the historic power imbalances in healthcare are not intentional. They're simply a function of history, and they continue to exist. In clinical settings, as a patient and as a caregiver, the reality is that I lack power and I worry about rocking the boat and negatively impacting or delaying care. I sometimes struggle with finding the balance between being assertive, but in the right way, of having my voice heard while not raising it too loudly, advocating but with a deferential smile. These perceptions often persist and carry over when a patient partner begins to do advocacy work. So it's really important to keep that in mind. The lessons learned through lived experience bring unique perspectives to the table. My perspective on the issue is often different from the clinicians or policymakers working on an initiative with me. Not better, not worse, but different. And that's why it's important that all voices be welcomed and included. I think that patients and their caregivers, those with arguably the most experience in healthcare, are among the most underutilized of all health resources. After all, along with those who provide care, who knows more about the system than patients and caregivers? It's important that patient partnership is embedded in policies and expectations of your organization through a commitment to evidence-based co-design. Co-design is an intentional way of working that adds lived experience to the design and programs and policies. It's where the science meets the subjective. Lived experience brings a focus to how well people understand a treatment, for example, how they feel about it while they're using it, how well it serves its purpose, and how well it fits into the context in which they're using it. So I won't go through what co-design is not. You can look at that later. I understand the slides are going to be on the website. So change is happening, whether or not we desire it. Change is disruptive, but it's also exciting and full of opportunity to influence what the face of healthcare looks like across Canada. There are bound to be rough waters. No meaningful change happens without agitation. COVID was an example of rough waters. The pandemic taught us that patient partnership that's done off the side of the desk as a nice to have, not a must have, can be tossed aside for the sake of expedience or in times of crises. My takeaway from this is that fragile and vulnerable things are often the things that crack first. Engagement and partnership activities were among such vulnerable innovations in healthcare that cracked during COVID. Many initiatives and patient committees were put on hold because they were considered less crucial. My takeaway from this is that fragile and vulnerable things need to be addressed. Engagement and partnership activities, I want to talk a little bit about what we did learn. During the cracks that we saw in COVID, we saw lots of imperfection. Examining these cracks, learning from them, and then using them reminds me of the Japanese art of kintsugi. The kintsugi master examines the crack lines of broken ceramics, then gilds them and finally recreates an object of beauty. I hope that we can take what we've learned during COVID to recreate engagement-capable environments in healthcare, in our hospitals, in our organizations, in the system, and that these engagement-capable environments will be crisis-proof. What I've heard tonight, it's clear that you clearly value the insights and contributions of patients and caregivers, and that gives me hope. It gives me hope that my family and the millions of Canadians like us can look forward to being at the center of care that will be designed with us, not for us. When I think about my family's experiences in the health system, I'd say that we've often received excellent, in fact, exceptional treatment, but we have not always received excellent care. And these are two different things. I want to end my few minutes with you by acknowledging that while clinicians in Canada continue to deliver on what patients need, you do this within the confines of a system that for the most part isn't delivering on what's needed to support you. You deliver in spite of the system, not because of it. So I want to take a minute to thank each of you for the care you give to your patients and for the part that you're playing in organizing and leading important patient safety initiatives. You make a difference, so I want to thank you for being the difference we need. It matters to us as individual patients, and it matters to Canadians who depend on the health system today and in the future. So thank you so much.
Thank you very much, Meiqi, for such a great testimony. One thing I learned from talking to patients who asking them what are the game changer factor for success in their outpatient surgery. One thing that I didn't expect, was the coordination, the knowledge of each team member transmitting the same information. So a patient needs to have a trust in the process, and to have trust in the process. If they ask the attendant, how long will be my surgery, and if they receive the proper answer, the trust is building up because all the team members are working for the patient. Let's see, do we have question for Meiqi in the chat?
I do have one question here surrounding embedding patient partners into the functioning of the hospital. Just a clarity of what exactly you mean by that.
So, I think what's really important, one of the things that we learned was how important it is to embed patient partners in your hospital. So what I mean by that is embedding patients as part of the decision-making in the hospital, part of initiatives from the very beginning. one of the things that sometimes happens with patient partners is that we're called in to validate a process or to, to give feedback after something has been developed, when in fact, the most that we contribute is in the design and the development of the program upfront. As I said, one of the things that's sort of I think about a lot is the fact that my insights as a patient and caregiver, again, are not better or worse than any of the clinicians that I'm working with. They're just different. And that fullness is what really adds to it. I'm just going to also make a plug for the making sure these patient partners are embedded. One of the things that we found during COVID was when patients were part of ad hoc groups, so advisory groups that just came together in an ad hoc way, it was easy to cast them aside during COVID, whereas if they're embedded in the processes and the hospital is very supportive of patient partnership, they become part of the process all the way along.
Thank you so much. Now we can start maybe a general discussion. If you have questions for one of the speaker, please put them in the chat room. We'll be more than happy to share these questions with the expert.
Pascal, can I ask you a question?
Yes, certainly.
I've had a number of requests. I think I put my email in the chat there. Will we be getting the registrants or participants emails as well? Just I can send a group email because some people have asked specifically about some of the protocols and criteria that we use. I'm happy to share them, but I can send them all out to surgeons or admins together if someone would like that.
I'm sure we can do it. Yeah, we ask the COA to share the link, the mails with you. I have a question maybe for Sebastian or Brent. You have a successful program in your hospital, low complication rate, high outpatient success. How do you maintain this success over the time? Team member, they get tired after a while, and then they tend to return to the original status. How do you maintain the interest and the success rate?
I think that's a good question. I think, you know what, especially after COVID, with our success, we've been able to redefine the new normal. Like now, like you say the normal of going back, but like when we admit patients, people are like, well, what's wrong? Why are we admitting this patient? Like, is there something, the normal for them is to have everyone go home. The normal for them is for everyone to be seen by physiotherapy and get going. And so I think you can successfully establish the new normal. And so I think part of the reason to set up a program that the norm is that you go home, or the norm is that you can safely bypass PACU. You have to establish these as the norms. Like it's a totally new normal. And once you get over that hump, then it becomes foreign to go backwards to the other way because that is your normal, right? I think if we treat these things as like very selective and very specialized, and the perfect patient can go home who's 50, low BMI, non-smoker, no narcotics, no stairs, 24-hour supervision, no medical comorbidities, ASA 3 or less, then no one goes home or no one can go, you know what I mean? We're so stringent. We rethink what normal is and why we are doing things. And I think it takes a while, but once you get administration, especially to buy in, and I think, you can speak to administrators, and I'm sure there are a lot of them on this call, but like is money talks. And if you can save money and save resources and have a better experience, people are happy. Patients specifically come to our institution because they're like, well, you have a same-day program. Like I want to go home the same day, And so I think once that reputation gets out, it's beneficial.
Thank you. Brent, something to add to this answer?
Yeah, so I do think it's a bit of a self-perpetuating, very much the same as what Seb was saying. I think it's self-perpetuating that patients that do go home successfully as an outpatient, they talk to their friends and their family, and you do have more patients interested in the program and it becomes a bit more smooth. I do think it does need to be recognized it's a little bit more work for us as clinicians in some ways to do outpatient. When they are outpatient, I do phone my patients post-op day one to make sure they're fine. And I check them before they go home to make sure that everything's going smoothly. So in my institution, in my experience, it's slightly more work. I do think that needs to be recognized as well. That it does take a little bit more hands-on and a little bit more personalized touch in some ways for ongoing success. But the rewards are definitely there, and that you have happy patients that self-refer, that talk to each other, and are very pleased not to stay in hospital. And it also, frankly, keeps your OR running better. If you're doing 3 outpatients, there's less bed crises, less bed issues, less likely to have a shutdown from it. So there's some benefits and opportunities within it.
Excellent, thank you. Some question in the chat. No. You discussed about the anesthesia technique. You know, having the anesthesia group on board it seems a very important factor of success in all hospitals. You know, when an outpatient protocol do not work well is because all the team member are not on board. Was it easy in your institution to get the anesthesia team following, let's say, one recipe to achieve an orthopedic outpatient success? Brent, maybe to start with?
No, definitely it wasn't easy. I'm sure all of us thought leaders had issues with people suggesting that it was, I'm sure Dr. Venditolli, I'm sure you had the same experience, people suggesting that it was unsafe, that it wasn't appropriate, that there was ulterior motives and all these, there was pushback. And thankfully it was often most of our patients were the strongest advocates to be outpatient. Once they learned it could be done, or they asked if it could be done, they were, in my experience, my strongest advocates to do it. So yeah, while there was barriers, the rewards were certainly there, and it became very evident that it was easy transition, especially when you're rounding post-op day one and the patients were dressed and ready to go. It became so evident that this was a natural progression. So I think that's why I mentioned that a step from enhanced recovery to outpatient, rather than go from 2 or 3 days in hospital to outpatient, that's not going to work as well as if you already have a streamlined process. You're managing your blood loss well. You're ready to have them hemodynamically stable when they go to the floor. So I think there's some natural steps towards success.
Excellent. One last specific question. Do you use the same protocol for your inpatient patients? I mean, do you try to provide the same focus, quality, ERAS protocol for your inpatient, or you just keep it for your outpatient? Sebastian.
We use the same protocol for everybody in terms of anesthesia, the blocks that they would get, medications. Obviously, if you're going home, the timing of these medications post-operatively or in your blister pack would be a bit different than if you're staying 1 or 2 nights because of logistical, social or medicine admission reasons. So some of the medications are tinkered, but overall the effect is the same. I think, to mirror what Brent said about anesthesia is by far the most challenging group. I mean, they're wonderful when everything is wonderful, but can be, an interesting group. I think if we're being honest, anesthesia groups that have a group billing practice sometimes are harder to manage than those that have an independent practice at our hospital. A lot of them are independent, like they're not a group billing, so they all collect. If they do extra blocks, anesthesia gets paid by block. Anesthesia gets paid for the people that they see in the block room, or we have a float anesthetist that helps sometimes with blocks. And so there's a great interest in this for our anesthetists, whereas in some institutions it's harder to convince anesthesia to do an extra case or to do certain things. And I think the focus in some of those institutions has to be the teaching factor, right? Like being able to do cool new anesthesia in terms of blocks and how it can be utilized and rapid recovery. I think you have to sort of show that you can use your learners to learn new techniques. For sure, we had pushback from anesthesia, both from a safety perspective and also from a standardization of protocol perspective. But we try to involve them, and there's been a lot of give and take. And even with our newer skip the PACU sort of program in terms of what was safe and acceptable. And usually as surgeons, we want everything, and then anesthesia pushes back, and then you sort of get to the middle, if you will, with a compromise. But I think once they see the benefits, it's good for everybody.
Excellent. Time is flying. Brent, oh, sorry.
One thing I do a little bit different is for my outpatients, I push a little bit harder for DEX intra-op. Sometimes they don't like to do DEX for the brittle diabetics and stuff. So, but that's the only difference I have from my outpatient inpatient. Otherwise, exactly the same protocol, surgical technique, everything the same. But I do push a little bit harder for DEX for my outs.
Excellent. It's already 20 past 9. Time is flying in this webinar. The discussion is great, but we will need to close the session. I think we could keep the chat room open for maybe a few minutes if the experts want to answer some of the question in the chat room. That would be great. But I would like to thank all speakers tonight, Dr. Guo, Danielle Jepson, Meiqi, Brent Lanting, and Sebastian Rodriguez for being with us tonight. And I hope we'll have the opportunity to have another session, a similar session organized by the COA another time this year. Thank you so much, all, and I wish you a good evening.